Good evening, everyone. Welcome to tonight's webinar. My name is Dan Green. I'll be your host this evening. Glad you all could join. Tonight is Sunday, August 14th, 2022. Given that it's a Sunday night, we will be doing caseless defense questions tonight, so we'll be taking questions from case lists that folks submitted. If you have not submitted your case list and you want to have an opportunity to be in the hot seat, please do email ExamPro about your desire to have an opportunity, as I said, to be in the hot seat, and also send in your case list so that we can pull it up when we do case list defense nights. Okay. So what I will ask is, if you have indicated your interest in being in the hot seat and you have not been in the hot seat, let's say last Wednesday, which I think was the last webinar, if you could raise your hand so we could get some volunteers. Okay, Kristen, I'm going to try to take you off mute. Says yourself muted.
Hi, can you hear me?
I can hear you. So Kristen, are you an MFM? I'm sorry, are you a generalist or are you a specialist? Excuse me.
I'm a generalist.
I was going to play, we'll do 20 questions. You MFM, you REI. All right. I'm going to show my screen, which you may recognize, perhaps with some disdain. This is your case list.
Ooh, yes.
Let's see. Patient number 4 is a 54-year-old. I'm going to read it. Just, can you see it? Big enough? Is it large enough?
It's large enough, yes.
Okay. Well, hopefully everyone else can see it, but I'm going to read through it really quickly. A 54-year-old G5P2 with abnormal uterine bleeding, polyp, a history of false passage during hysteroscopy polypectomy. She had a failed endometrial biopsy, was treated with progesterone. The ultrasound showed a polyp, hysteroscopy, DNC, polypectomy, and she had a progesterone IUD placed under ultrasound guidance, and the pathology was benign. So, first of all, what's the PALMCOEIN nomenclature for abnormal uterine bleeding?
So it's on one side, polyps, adenomyosis, leiomyomas, and malignancy. COEIN, coagulopathy, ovulatory dysfunction, endocrine abnormalities, iatrogenic, and not otherwise specified. And I think I messed up the E and I.
I'm sorry, say that again?
I said I think I swapped the E and the I, but endocrine abnormalities, or endometrial abnormalities rather, and iatrogenic.
Okay. If somebody had a thyroid disorder that was affecting their menses, where would that fall?
That would fall under, that would affect their ovulation, so it would fall under ovulatory.
Okay. What about endometrial? Let's say somebody had benign endometrial hyperplasia. Where would they fit?
With it being benign, that would fall under endometrial abnormalities.
Okay. So what are risk factors for endometrial hyperplasia?
Risk factors would include things that would increase estrogen. So things such as whether it's medication induced and it's taking estrogen by itself, whether there's unopposed estrogen from anovulatory cycles, whether there's an excess estrogen from elevated BMI or adiposity in the tissue. Those are the main three I can think of.
So let's say this patient, well, first of all, you created a false passage. When you do a DNC hysteroscopy, obviously there's a whole bunch of things that can increase a patient's risk, but in general, what's the incidence of perforation?
About 1%.
Okay. What about in a postpartum patient?
It would be higher in a postpartum patient. So I would say probably somewhere around 5% or.
Okay. So let's say, but you didn't perforate, or this patient hadn't had an actual perforation, is that correct?
Correct. And the history was about 15 years ago on the last time she'd had a hysteroscopy.
Okay. So if you were doing the hysteroscopy and you suspected perforation, how would you manage it?
First, I would assess the patient's stability. So making sure communicate with anesthesia to make sure that her vital signs were stable if we're in the operating room. If we weren't in the operating room, I would get a set of vitals. The next thing I would assess is what I had suspected that I perforated with. So whether or not it was perforation with a dilator or perforation with a sharp instrument. And I would also think back to all the instruments I had used so far. So if I hadn't even used, if I had perforated with the dilator and I had not used any other instrumentation at that point, then I would be fairly well assured that it was a blunt instrument, because if I had used a sharp instrument, then I would need to evaluate for concern, or I would have to evaluate for possible injury to other organs inside of the location.
I'm sorry, does the location, by the way, they will interrupt you periodically, especially if you're talking too long.
Okay.
Does the location of the perforation affect your treatment or decision making? Or suspected location of the perf?
Yeah, if I suspected that the perforation was more lateral into potentially a uterine artery or major blood vessel, then I would that would make me more concerned.
What would you do in that situation?
Again, I would assess for hemodynamic stability to assess how quickly I needed to intervene. But if I was concerned for a major blood vessel injury, and then I would potentially need to intervene with a laparotomy. But in general, I would do a diagnostic laparoscopy if my patient was stable.
All right. What if you suspected a perforation straight through the fundus? What would you, let's say with a dilator or sound, what would you do, if anything, at that point?
So if I suspected it was due to a blunt instrument straight through the fundus, then risk of injury to bowel or major blood vessel is going to be low. And so I would stop the procedure. I would observe her and collect a set of labs. I would observe her for several hours to make sure she was stable.
So you'd get a set of labs. You mean when she hit the recovery room?
Correct.
Okay, so what labs would you check?
I'd check a CBC and potentially a CMP as well.
What are you looking for on the CMP?
To assess her sodium level to make sure that she wasn't becoming hyponatremic.
I mean, would you suspect she's hyponatremic? When you have other indications, perhaps, that the patient might have a sodium issue? I mean, like perhaps fluid deficit or
altered mental status.
Is it likely?
It's very unlikely.
Right. I mean, especially if it's with a dilating instrument.
Correct. It is.
So presumably you haven't inserted the hysteroscope at this point.
Correct. Yeah, you'd be correct. So primarily the CBC, just to ensure that her hemoglobin was stable from some preoperative established value if I had it.
I mean, would you expect the hemoglobin to change that quickly?
No. It would be more of also a baseline to see in the future as because it would take several hours for equilibration.
So would you so you'd keep her for several hours and do a repeat set of, or a repeat CBC, is that correct?
Not I wouldn't necessarily keep her for a repeat CBC. It would depend on her vital signs. So if she was not tachycardic and not hypotensive, then I wouldn't feel the need to get a repeat set of labs.
Okay. So last question. You told me benign endometrial hyperplasia would go under the E category. Actually, last question and a half. Can you give me another example of an endometrial cause?
Potentially, if in postmenopausal women whose endometrium is very thin, they could have an atrophic lining that could have some spotting.
Okay. Now this really is the last question. So you mentioned benign hyperplasia again under endometrial. What about EIN? Patient had endometrial intraepithelial neoplasia. Where would that go?
I would place that more under the malignancy category, although it's not in and of itself a malignancy. There is up to a 40% chance that those patients would actually have a malignancy. So in the way I would organize it would be putting it into the malignancy category.
Okay. I think we will stop there. Very nice job. So I guess we'll go over it. By the way, folks, we'll stop about 10 minutes before time's up at the end, and we'll go over any remaining questions that folks have. And if we go over, we go over. But so if you do have questions, you can hang on to them until then. So the abnormal uterine bleeding, so you were correct. Your PALM and your COEIN, your coagulopathy, ovulatory, endometrial, iatrogenic, and not otherwise specified. Yeah, the E is not endocrine, which again, you corrected yourself, so nice job there. You mentioned atrophy in a postmenopausal patient. That's exactly correct. The typical E's that I think of would be atrophic endometritis or like a chronic endometritis. Yes. Your benign endometrial hyperplasia actually should go under malignancy, even though it's not a malignant condition.
Okay.
And I'll explain to you why in just a second. Your risk factors for endometrial hyperplasia were good. The biggest one is going to be obesity, closely followed by unopposed estrogen, including anovulation or iatrogenic unopposed estrogen. Some could say, well, wait, that's iatrogenic. Well, if you give the patient, oh, I'm sorry, I'm confusing two things. Even though it would be created iatrogenically, it would still be the second leading cause of endometrial hyperplasia. The next big one, and then after this one, they all become much more minor, would be tamoxifen. The relative risk is a little bit over 3 for tamoxifen versus like 9 or 10 for unopposed estrogen and obesity, respectively. So you can see it drops off. But then when we get down to the more minor things like hypertension, diabetes, we're talking about like in the 1 to 2 range in terms of relative risk. And of course, nulliparity, early menarche, late menopause, and family history would all be potential risk factors. Your perforation numbers were spot on. So very, very good job. It is 1% overall with DNC hysteroscopy. And you're right about pregnancy. It does increase the patient's risk of perforation, and it's in line with about 3 to 5%. So, recent pregnancy, or just immediately postpartum. So nice job with those. So let's see. Oh, the perforation. So you're right. I would suggest from a technique standpoint, Kristen, you want to try to be a little bit more concise with your answer. Because you were dragging out a little bit. Well, is she hemodynamically stable? Obviously an important factor. But when you were, what I was looking for was for you to say, I would check if I were concerned that I perforated laterally, I would ask for her vital signs. And, if she was becoming unstable, I would proceed to do either laparoscopy or laparotomy. Generally speaking, unless she's becoming critically unstable, it would be laparoscopy, to assess. And then, let's see, fundal perforation certainly could observe the patient. Again, want to try to pay attention to detail, because if you're dilating or you haven't placed the hysteroscope, presumably at this point, and even if you've placed it, she's not going to be fluid overloaded from, 2 seconds with the hysteroscope in place.
Okay.
Even with a perforation. Not the end of the world getting a CMP, but, when you get into the sodium aspect,
I don't want to do that.
I think I convinced you that maybe it wasn't right.
Yes.
And then, let's see. So I think that pretty much takes care of where we're going. And you're right, it's going to take 4 hours to equilibrate the hemoglobin. So it's really not going to give you any information except for perhaps a new baseline from which to start. Now, the reason, by the way, endometrial hyperplasia and EIN all go in the malignancy category, if you think about PALMCOEIN just at a high level, it's structural versus non-structural. So, for example, if someone has a coagulopathy, so they have a problem clotting, you can't hold a coagulopathy in your hand. I mean, there's not, what are you going to hold? Some amino acid or some gene or who knows what? You can't hold that in your hand. But what you could hold in your hand, if I did a DNC on a patient with benign hyperplasia, you can hold that tissue in your hand. I did a DNC on a patient with cancer, and I had cancerous glands that I'm giving you. You could hold that in your hand. Same thing with EIN. Same thing with a polyp. Same thing with a fibroid. Same thing with adenomyosis. If somebody, again, has PCOS, you can't hold the hormone in your hand, really. So that's kind of one way I suggest the folks to think of it. Sometimes it works for them and it's easier for them to think of it that way, and sometimes not. But that would be what I would suggest.
May I ask one question about I tend to place levonorgestrel IUDs pretty liberally, especially if they're under anesthesia. And so I wasn't sure if I'd get some questions as to why I placed it in a 54-year-old. I did it because she was having abnormal bleeding, and if I remember, and her BMI was around 28 or 29. So I was thinking that perhaps there was, and she'd given me a history of abnormal menses in the past. And so I thought that this might help prevent us from needing to go back to the operating room for another DNC in the future to diagnose abnormal bleeding, but that I'm not sure if I might get questions about that.
You could get questioned about it. I mean, as long as you're sure that this is abnormal uterine bleeding and not postmenopausal bleeding, I think it's, very reasonable to place the IUD. And I'm not saying you couldn't place it even in a postmenopausal patient who had, for example, hyperplasia. The one caveat, though, for this particular patient is she had endometrial polyps, and the progesterone in and of itself is not going to necessarily prevent polyp formation.
Correct.
So, again, it's just like if she were 48. I mean, she might, stop bleeding in 6 months, but she could have periods for another 3 years. I mean, without the IUD. So who knows? So it's not unreasonable to place it as long as she doesn't have any risk factors.
Okay, thank you.
Sure. Thanks for volunteering. All right, guys. I will take the next volunteer. So give me 1 second here. Sharon, you said yourself muted there. Sharon, are you able to take yourself off mute?
Yeah.
Can
you hear me?
I can hear you now. So are you a generalist or specialist?
Specialist.
What's your specialty?
GYN oncology.
Ah, we could have used you for the last case. Not really. We would have done something different.
Yeah.
All right. Well, I see you don't have an OB list up here, understandably. So I think we'll go to your office listing. Yeah.
Okay.
All right, let's see. Guess what? Everybody has cancer. So patient number 1 had a history of gastric cancer, and she was found to have an incidental cervical mass on staging. She's 75 years old, paras 6. Your PAP was negative, her MRI was normal, and no cervical mass was detected on your exam. So she is under preventive health care and maintenance. So tell me, what would be your criteria or recommendation to send this patient for a bone density scan?
Typically, they start bone density scans at age 65. However, if she had other risk factors, I could plug her information into there's the frax calculator. But if she's been on anti-hormone therapy or she went into premature ovarian failure, like if I gathered those things on history, those would be signs that maybe she has weakened bones and could warrant additional testing. But typically,
you mentioned
65.
I'm sorry. You mentioned premature ovarian failure. So if you had a patient with premature ovarian insufficiency, could that patient have her risk factors placed into the frax tool to help decide whether or not she's a candidate for early DEXA?
I don't I don't think I'm unsure if that's one of the variables to be listed on the frax.
I'm sorry, to be listed? I didn't hear you.
Yeah, I'm not sure if that's one of the things, one of the variables on the test.
So let's assume it's not, just hypothetically. I mean, would that matter? Could you still take her risk factors in general and put them in the frax tool to come up with a meaningful answer?
I would say yes.
Okay. So let's say this patient last had a DEXA scan at age 68 and it was normal. She hasn't had one since. As part of your preventive health screening, would you recommend she have another DEXA scan at this point?
I would individualize it with her because she's 75 and had normal testing before, but I would probably lean on getting her another one if she was comfortable with it.
Okay, so if she were comfortable with it, you mean because she's concerned about the pain with the exam, or what would make her uncomfortable about it, I guess?
No, I'd say uncomfortable with sometimes, not that this is a good excuse or reason, but some of the elderly patients don't want to do any testing no matter what you say. But I'm saying in general, I would stress that she may have, I don't want her to have a fall and break a bone that could be prevented if she just had the scan, and we can get her on the appropriate therapy to make sure she doesn't get a hip fracture or some other major fracture.
So I guess the bottom line is you would obviously the patient can always refuse, but your recommendation would be that she should have another scan, should have a scan. Is that correct?
Correct.
Okay. So let's say let's say she, you're the doctor and she'll listen to your suggestions. So you do a bone density scan, and let's say her T-score comes back as now minus 1.8. I mean, just because she had a normal one at age 68, now she's had cancer, who knows what treatment she's been on. So let's say again it's minus 1.8. Would you recommend treating that patient?
No, I believe that's in the that might be the osteopenia range. So I would calculate her actual future fracture risk before assigning treatment.
And how would you go about doing that?
If based on her risk factors in the frax calculator, if she had a 3% risk of a hip fracture or 10% major other fracture in it's 20%, 3% and 20% risk, then that would warrant treatment.
Okay. So let's say she had a 5% hip fracture risk with that minus 1.8 and her risk factors. What would you recommend treating her with?
Bisphosphonate therapy.
Okay, and what are contraindications to bisphosphonates?
Hypocalcemia. Of course, if she had an allergic reaction to the class of drugs. I would think the main one sticking out to me is the hypocalcemia. That's the big one.
Okay. So let's say you start her on a bisphosphonate. When would you want to revisit this? Obviously, you're going to check, I'm sure, whenever you see her next to see how she's tolerating the medication, but let's assume she's tolerating it okay. When would you want to reassess her bones, if at all?
No sooner than 1 year after starting therapy.
So would you do it in a year?
I would.
Okay. Any idea what the margin of error of a DEXA scan is?
I am unaware of the margin error on a DEXA.
How about the best case scenario performance in terms of bone, I'm going to say bone building here, but air quoting with that, with bisphosphonate. So how much in terms of increase in bone density under the best circumstances would you expect from bisphosphonate?
I'd say maybe, a 10% improvement in a year.
Okay. How long would you treat the patient with a bisphosphonate?
I believe it's recommended to reevaluate after 5 years of bisphosphonate, whether or not you need to continue. I don't think it's recommended beyond 5 years.
You mean to keep the medicine going at beyond 5 years, or do you mean to not wait more than 5 years to do another DEXA?
I was speaking about being on bisphosphonates for 5 years or more. That's what I was saying.
Okay, so let's say in 5 years the patient still is at moderate increased risk for bone fracture. What would you do?
I'll have to double check the how if it's not really a 5-year contraindication, I would individualize it with the patient and recommend continued treatment if it was safe to do so.
Okay. All right. Let's go over this one. So pretty good job. You did say you probably at first when I was asking you about in terms of your recommendation, what would you recommend to the patient? You said something along the lines of I probably would recommend she have one, and then you were a little bit more definitive when I pushed you. In general, is it Jaron? Is that how you pronounce your name?
Yeah, that's my first name. Yeah.
Yeah. Okay. we're keeping it informal here.
Yeah, no, it's okay.
So, try, and this is not just for you, of course, Jaron. Applies to everybody, which is why I'm bringing it up. We want to try to eliminate qualifying words in our recommendations or discussion. I might consider, I could, because when we say things like that, all it serves to do is make us sound less certain about our answer. I'm probably going to recommend she has one. Well, okay, when you figure out if you are or you aren't, call me back and let me know. I'm obviously taking it to the nth degree, but it makes the candidate sound less certain, like somehow we're going to get feedback from the examiner in terms of, yeah, that sounds like a good idea, or they'll be nodding their head yes or shaking their head no. None of that's going to happen. It's very unnatural in terms of how stoic these folks are. So when we say things like that, we're not really helping ourselves. We're just sounding less certain. Again, and we do it because if they really push back and said, you're going to do it, and she just had a normal one, 7 years ago, what are you thinking? You could always fall back and say, I said I probably would. I didn't say I definitely would. Like somehow we're going to have that debate with the examiner, and that's not going to happen. So,
okay.
As we get closer to the exam and you do more and more practice, you'll want to try to make sure that you don't use the qualifiers. And everybody does them. I do it sometimes myself. It's all part of our normal speech pattern, but it only serves to make us sound less certain. So that's the first comment I would make. In terms of, would you get another DEXA? You're right in terms of, you mentioned early DEXA before 65, and 65 is the age that all folks should have a DEXA. But sometimes we do get them earlier. And again, you plug the risk factors into to the frax tool and come up with a number. And, depending on the number, it determines whether or not we should recommend an early DEXA. In the case of the premature ovarian insufficiency, however, that you brought up, what's the definition of premature ovarian insufficiency?
It's ovarian failure prior to age 40. I think
That's
40
correct.
and below. Yeah.
Okay, and do you know what age the DEXA scan is validated to? Or the DEXA, I'm sorry, not the DEXA, the frax tool is validated to?
I do not know.
Oh, I'll give you a hint. Why am I asking you this question?
75?
No, it's 40.
Or, no, sorry, no, 40, 40. Yeah, no,
So basically, the frax tool should not be used on patients less than age 40. So if you have a patient with premature ovarian insufficiency, let's say she's 38 when she, stops having menses, what have you, you can't use the frax tool on that patient. She's too young. So she would not be necessarily a good candidate for the frax tool. I'm not saying that we wouldn't get a DEXA on her, perhaps. But she would not be a good candidate for the frax tool. So let's see. You were correct with what you said about the calculating for the low bone mass or osteopenic minus 1.8. You would put her risk factors back into the frax tool and calculate her risk. And if she has, as you said, 3% hip fracture risk in the next 10 years or greater than 20% major osteoporotic fracture in the next 10 years, she would be a candidate for treatment. And typically bisphosphonate would be the first line that, as you know, it's going to inhibit bone resorption. So it inhibits the osteoclastic activity. One thing I didn't ask you, how much calcium and vitamin D would you recommend for this patient?
I believe it's 1,200 milligrams of calcium per day, and I think 800 milli-international units of vitamin D?
Very, very close. It's 1,200 milligrams of calcium and 800 international, not milli-international.
Okay, yeah.
And that changes, as you know, at age 70. Okay, so the bisphosphonate, you said hypocalcemia, that's correct. Allergic to the medicine, of course, that's correct. The other things would be if they have renal impairment would be a concern. If they have a history of GERD or peptic ulcer disease or esophageal strong esophageal irritation, these would all be contraindications. if they can't sit or stand for 30 minutes after ingestion, that would be another contraindication. So you said you'd get another bone density no sooner than 1 year. Really, you shouldn't get it any sooner than 2 years. And why I got into the questioning about the bone density and the margin of error and the optimal bisphosphonate bone building, if you will, or improvement in bone density, has to do with this. The margin of error of a DEXA scan is about 4%. So if I do a DEXA on you right now and I do another one 10 minutes from now, the results could be plus or minus 4%. Bone building for a bisphosphonate optimally would be about 2 to 3% per year. So if we build bone, let's say we have, the patient's taking it religiously and she's responding wonderfully. If we get a bone density in a year and it's plus or minus 4%, let's say in this case it's minus 4%, and let's say our bone building is plus 3%, we're going to look at this DEXA and go, wow, she's still losing bone on this bisphosphonate. So we could incorrectly interpret the results, which is why it's really not a great idea to get the DEXA in a year's time. You could falsely interpret that the patient is not responding to therapy. Whereas even if she's like 2% per year for 2 years and it's a minus 4, the worst we're going to see is that she's neutral. And if she's neutral, we're happy.
Okay.
So we typically would repeat it in 2 years, and if her DEXA is stable or better, would not have to repeat it again until we're going to stop the bisphosphonate, and that would be basically to establish a new baseline is why we would get the DEXA at that point. Now, we would get another DEXA after the first one at 2 years if the patient developed new risk factors for osteoporosis. So let's say she developed some rheumatologic condition that she needed to be on chronic steroids. Okay, new risk factors, so we would want to repeat the DEXA in 2 years after the last one. Last question, I think I asked you, what you said you'd stop it in 5 years. So that is strongly gaining traction. It's pretty well established in the primary care, from the primary care folks like the internists and family practice. They're certainly not letting people be on it more than 10 years and definitely moving toward 5 years in terms of stopping. It's not quite the hard, fast rule for OB yet, but certainly, again, gaining in popularity, that trend. But if you did stop the patient and she still needed therapy, you could always try something like, you could try a rank ligand inhibitor, or you could try something like a Vista, raloxifene. If the patient still needed to be on therapy. And I think that is it. I think we went over everything I asked you.
Okay, thank you.
My pleasure. Thank you. Okay, so let's go for another volunteer. So Matthew, looks like you have your hand up. Matthew, are you volunteering? Says you're self-muted.
Yes, I'm volunteering.
Okay, great. And did you send your list in?
Yes.
You did. Are you a generalist or specialist?
Generalist.
Woohoo! We can do an OB case. Aren't you excited about that?
I'm so excited.
Try to contain that excitement there, big guy. All right. So let's see what we got here. Patient number 3 is a 31-year-old G3P2 at 38 and 4. Had unstable fetal lie, chronic hypertension, and obesity. She was placed on aspirin, weight management counseling, antenatal fetal surveillance. A prior provider did a version. She was induced and she delivered vaginally with good APGARs. So what risk does obesity convey to pregnancy?
Obesity has, I guess with regard to pregnancy, is increased risk of spontaneous miscarriage, also increased risk of insulin resistance and gestational diabetes, hypertensive disorders of pregnancy, preterm birth, And then as far as intrapartum risks, possibly prolonged second stage, and well, excuse me, prolonged labor.
Okay. So give me 1 second. I'm just making some notes here. Does obesity increase a patient's risk of congenital or the baby's risk of congenital anomalies?
Occasionally, yes. Sorry, let me take out the qualifier. Yes, it can. There can be.
Which ones?
So facial abnormalities, cleft lip, cleft palate, occasionally heart defects. And you said it was related to birth defects, correct?
Congenital anomalies, yeah.
Congenital anomalies, okay. Yeah, so heart defects, cleft lip, cleft palate.
So you have weight management counseling here, which kudos to you, by the way. I like how you phrase that. That's terrific. So how much weight would you recommend a patient limit themselves to in pregnancy if they start out obese?
11 to 20 pounds throughout the entirety of their pregnancy.
Okay. And I don't necessarily expect you to remember this, but you have no idea what class obese patient she was, do you?
I do not recall, no.
Okay. So when you have an obese patient, I see you have antenatal fetal surveillance, but that could be in this particular case due to the patient's hypertension.
Correct.
Do you recommend increased antenatal surveillance on obese patients? So if that were her only complication, for example, would you still have done increased surveillance?
Yes, patients over with BMI of 35 or above do get antenatal fetal surveillance.
So when would you start what would you do and when would you start it? Let's say her BMI is 36.
In my practice with a patient of BMI of 36, we would start once weekly NST with fluid assessments starting at 36 weeks and continue them weekly until delivery. Okay.
So what if she were, let's say her BMI was 41, would that change your management at all?
Yes, so we typically would start those patients with twice weekly non-stress tests with fluid assessment, starting at 34 weeks gestation and continuing until delivery.
Okay. So give me 1 second here, just making another note. All right. Let's see. So she had an external cephalic version. I assume she was, well, I don't know. I'm guessing maybe she was breech. So how successful are versions?
It's very provider dependent, but typically around 50%.
Okay. And what are contraindications to version?
Contraindication to version are basically any contraindications to a vaginal delivery. That includes like vasa, placenta previa. That includes active genital herpes outbreak. That also includes twin gestation, which is not a contraindication to vaginal delivery. Relative contraindication is also oligohydramnios. Most providers in my practice do not perform ECVs on oligo or ruptured patients.
You mentioned vasa previa. What's a vasa previa?
Vasa previa is when vessels of the placenta are overlying the cervical os.
Okay. What gestational age do you normally do your versions?
37 weeks, 10 to 37 weeks gestation.
Okay. Did you do anything special for this patient, given the fact that she had chronic hypertension? I see you put her on aspirin. What are what are your criteria for recommending aspirin in pregnancy?
So patients that may be at risk of preeclampsia later on in pregnancy, so those with pre-gestational diabetes, those with history of preeclampsia, those with autoimmune disorders, any one of those would require, or I would recommend aspirin. Patients who had several risk factors, that includes nulliparity, advanced maternal age greater than 35, obesity, low socioeconomic status. Those patients would also be, if they had two of those factors, would be candidates for aspirin therapy.
Okay. Very good. Great job. I think we will stop here and go over it. So, nice job. It's not critical to remember. Obviously, you have 36 pages of cases here. It's not critical to remember what the BMI was specifically for each patient. That would be, you know, I'm sure you have quite a few obese patients. I haven't looked at your list, but if a question like that were to come up, you could say, you know, I don't recall her specific obesity, but in general, you know, I divide them into class 1, 2, and 3 based on their BMI. And for class 2 and 3, I would recommend increased antenatal surveillance if that was the kind of prelude to the question, if you will.
Okay.
And again, it's not critical what she was. It's more critical that you know in general how you would manage it. It's kind of like, you know, somebody having arrested dilation at 6 centimeters or 8 centimeters. It's like, who cares? She's arrested dilation. As long as you know that, it doesn't really matter whether she was, you know, 6, 7, 8, 9. You know, it's kind of irrelevant. I mean, it's relevant for the patient specifically, but not in terms of your management. All right. So getting back to the obesity. So you gave me a lot of good things that, well, not good things, but a lot of correct answers in terms of risks of obesity and pregnancy. A couple others, you mentioned diabetes, hypertension, miscarriage, preterm delivery, prolonged labor, all of which are correct. C-section would be increased, wound healing, poor wound healing, macrosomia, shoulder dystocia would all be increased. In terms of cardiac anomalies, and congenital anomalies, obviously not as, we're going to miss some congenital anomalies because of the body habitus with ultrasound. So decreased detection rate, cleft lip and palate would certainly be one. Cardiac, and cardiac is probably thought to be due to perhaps undiagnosed pregestational diabetes. And to that end, neural tube defects could also be included in there. 11 to 20 pounds was good in terms of the counseling. And again, I really like that you listed weight management counseling. A lot of times people just, you know, they don't mention it. And I like the fact that you listed it at a high level because it gives you an opportunity to kind of really go through it if you want to. So your testing is fine. If I'm not mistaken, though, I do think, Matt, or Matthew, I'm not sure which one you go by, but I think for the class 2 obese patients, I thought it was 37 weeks was the recommended start date. Not a problem that you're doing it early, but you would want to distinguish that, assuming I'm correct, at the 37 weeks. Do you recall offhand?
I don't recall offhand. I was going off of the MFM recommendations that we have at our institution.
Yeah.
I think they started it.
And again, and that's totally fine. But I would double check because I think it's 37. You could say, well, you know, you could always say, you know, in our institution we use 36 weeks. Although I understand that, you know, some would wait till 37 weeks, something like that. Why do you do it earlier? Well, you know, out of an abundance of caution. I mean, you could say there's a whole bunch of ways you could answer that. In terms of your version, I think you said you gave me a bunch of good contraindications. Placenta previa, you said vasa previa, of course, which would be true. Placenta previa, of course, would be another. Multiple prior C-sections. If the baby had any anomalies that were contraindications to vaginal delivery, perhaps like hydrocephaly or something like that would also be. But now we're starting to get down to the nitty-gritty. Your aspirin was good. A couple other things. So obviously somebody who's, you said pregestational diabetes, preeclampsia, autoimmune, multiple gestation would be another risk factor. I believe that's chronic hypertension would be an obvious one. And nulliparity, I think, is a the medium weight, because you need 2 medium weight or 1 heavy weight. That's probably an unintentional pun. I mean, 1 major risk factor. Anything we didn't cover? Any questions, Matthew?
No, I don't think so. I think that's.
Well, you did a nice job. Thanks for volunteering.
Thank you.
My pleasure. All right, so I think we'll pause here for a second. We're at like 9:21 or so, and we'll see what questions we have, and then if there's time, I'm happy to do another case. So let's go to the questions, which should be, there they are. Okay, someone confirmed, thank you, Joe, it is 37 weeks. And actually, Shimona also confirmed that with us. So thank you both for looking that up and double checking for us. So again, Matthew, you just would want to make sure that you indicate that you know what the recommendation is and why you deviate. I mean, we're talking about an NST. We're not talking about a surgical, brain surgery here. We want to avoid over testing, but we're not talking about you doing it at 30 weeks and the recommendation is to do it at 37. So I think it's kind of a minor point, but if you're doing it a little bit earlier, you want to just let them know that you know the actual recommendation. So thank you guys both for checking that out for us. Does anybody have any questions about anything we covered tonight or in general about the exam that I might be able to answer? So feel free to raise your hand at this point. I'm going to I think everybody has their hand down, so we'll make it easy. If you put your hand up, I'm happy to take you off mute. Matthew? Oh, hang on. There we go.
Yeah, just had a quick question. So I think it was mentioned that the early DEXA, like a DEXA earlier than 65, would be based on the frax score. What is the score? 10% major osteoporotic fracture risk within 10 years? I forget the.
Yeah, so actually the real number, or the newer number, if you will, is 8.4.
Oh, that's right.
So if they have, and it's a 10-year hip fracture risk. So, and basically what that's saying is you're saying this, I'm making up the number, but let's say a 57-year-old, we put her in the frax tool and with her risk factors, and she comes out at, let's say, 8.6. We're saying that this 57-year-old with her risk factors has a little bit higher risk of a fracture than a 65-year-old. And we know the 65-year-old, we would get a DEXA. So therefore, we should get it on this patient because she's at every bit the risk that the 65-year-old is, plus maybe even a little more. Although it doesn't have to be plus 4, it could have been 8.4 on the button.
Okay, thank you.
Thank you. Anybody else have any questions? Going once, twice. Okay. Joseph, trying to take you off mute.
Yes, I had a question regarding the frax. When you said the T-score, if it's minus 1.8, that you would then use the frax calculator and then decide if she's a candidate?
Correct.
Okay. Because
I'm sorry, is Joseph your last name or first name?
Yes, my last name. Evrose is my first name.
I'm so sorry.
It's okay.
Yes, 1.8, yes, you'd want to use the frax tool. I'm sorry, I interrupted you.
Okay. No, I was just under the impression that if someone has a low bone mass, that you could just go ahead and treat them. But you said you would need to repeat the frax or do a frax for that patient.
Yeah, so if somebody comes back as what we used to call osteopenia, which is now considered low bone mass, which would be a T-score minus 1 to minus 2.49, we would take that T-score and plug it into the frax tool. It may be the first time we're using the frax if she's 65 or older. But in any case, we would take the T-score with her risk factors, put it into the frax tool, and if her 10-year fracture risk for a hip fracture was 3% or greater, or 20% or greater of any major osteoporotic fracture in the next 10 years, she would be a candidate for treatment. If she's osteoporotic, so a T-score of minus 2.5 or lower, so minus 2.8, minus 3, then we don't need to go back into the frax tool. She's got osteoporosis and would be a candidate for treatment.
Thank you.
Thank you. Any other questions, guys? No? All right. I'm going to do a 2-second question for somebody. So somebody volunteer, please. It's not going to be from your list because it'll take too long. Oh, come on. Matthew's volunteering again. There you go, Melissa. Thank you. Matthew, appreciate the volunteer. Melissa, it says you're self-muted.
Hi.
There you go. How you doing?
Great. How are you?
I'm doing well, thanks. Are you a generalist or specialist?
Generalist.
Okay. Tell me, what is meant when we say someone has a favorable cervix?
Favorable cervix is usually making an indication based off of their Bishop score. So usually a Bishop score of greater than 6, or actually even a Bishop score of even 8 would be considered favorable.
Okay. If someone is, let's say someone has a Bishop score, well, first of all, what's the maximum somebody can get with Bishop scoring?
Oh, 1, 2, 1, 2, 3, 1, 2, 3. Is it, I believe it's 2, 3. I want to say 12.
Okay. What are the components of a Bishop score?
Position of the cervix as far as oh my goodness. Okay, so dilation, fetal station. I love these. You like blank out for no reason. Dilation, effacement, station, position as far as like anterior, mid position, or posterior. 1, 2, 3, 4. And like firm versus softness of the cervix.
Okay. You said effacement, right? I think I talked over you. Okay. All right. So there's 5 components, and you said we could get a maximum of 12 points.
There's at least 3 of the components you can get 3 points for, but there's a couple of them that only you can get a max of 2.
All right. So if there's 3 that you could get 3, that's 9 points, right? And you said a couple, so I'm assuming 2 that you could get 2 points.
Okay,
so
11.
That's what?
11.
11? How about we go to 13?
Okay, that's good too.
Okay. So if somebody had a Bishop score of 10, so we would consider them favorable, as you indicated earlier. What is exactly someone with a favorable cervix? What exactly does that mean?
Well, when we're planning on using this term, the most likely setting in which we're having a discussion on this is a possibility of a decision for a setup for an induction.
Okay. So if we're going to induce somebody and she has a favorable Bishop score, what does that mean? Or favorable cervix?
That would mean that she has that her risk factors is she would have a potential of a lower risk for requiring a cesarean section.
Lower risk as compared to what?
As compared to somebody who is having an induction with a Bishop score of say 2.
Okay. Does it predict in any way whether or not we'll be successful with our induction?
No, it does not. It doesn't take into account as far as, like the patient's pelvimetry or the size of the fetus or other factors that may contribute to the requirement of a cesarean delivery.
You said pelvimetry? Is that right, Melissa?
Yes. Yeah, don't ever use that word in the exam.
Well, I never would, because I would be afraid they're going to ask me how to
Yes.
how to talk about clinical
I won't say
pelvimetry.
it after tonight. That's for sure.
I'm not going to do that to you because of the time element, but if you're going to mention something like that,
Yep,
they might say, well, how do you do clinical pelvimetry? What are the 4 shapes of a female pelvis? Now, if you're a clinical, if you're a pelvimetry expert, then that's great technique. But if you're somebody like me who's a pelvimetry, moron, for me anyway, it would not be something I would bring up voluntarily. But in any case,
I was getting it out.
Good. Getting it out of the way.
Yes.
Good job. All right, great. Let's go over this one real quick. So the take-home point here is you need to know the definition of all the terms on your list. So, I haven't seen too many folks this year write favorable cervix when doing case list reviews, but sometimes people do it, and it's perfectly fine, but you need to be able to define it. So most would consider a Bishop's of 8 or greater to definitely be favorable. A little bit controversial. Some people do use 6, but anyway, the total number of points you can get is 13. And you're right, there's 3 that have 3 points and 2 that have 2 points. Since we never did formal Bishop scores in training, I had to memorize this for the boards. So I created my own mnemonic. We never want to deliver a baby with that's been exposed to DES, which for us, DES hasn't been on the market since the late 50s. I don't think that's going to be a problem, but we certainly, and even now it's too late for patients that were exposed to DES really to be having children. So it's much less of a concern. But all the same, DES, it's the same thing we would tell the nurse when we're doing our cervical check. Dilation, effacement, station. There's 3 letters, therefore there's 3 points each for those. Consistency, position. So we never want to deliver a baby that has CP. So that's a way to remember the CP part. There's 2 letters in CP, ergo there's 2 points each. So 3 times 3 is 9, 2 times 2 is 4, so 4 and 9 gives you 13 points. When someone has a favorable Bishop score, basically what that means is it doesn't predict that they're going to have a vaginal delivery, but what it does say is if you have a favorable Bishop score and I induce you, your chance of a vaginal delivery is the same as if you came in active labor. She still might end up with a C-section because she, could have an abnormal fetal tracing or what have you, or she could get stuck at, have an arrest of descent. All those things are possible, but whatever the reason for the C-section, if she ends up with one, it's not likely to be due to a failed induction. It's not likely that we couldn't get her into active labor. So that's what we mean when we say that somebody has a favorable Bishop score or a favorable cervix. Okay, I'm going to pause one last time for any questions. If anybody has any questions or comments about anything we talked about tonight, please just raise your hand. Okay, not seeing anybody's hand. I want to thank you all for your attention and participation tonight. I'm not sure which night my next webinar is, but I think it's a week from Tuesday. I'll look forward to speaking with you again. In the meantime, there will be someone else tomorrow night who will be conducting the webinar. Good luck with your board preparation and talk to you all soon. Thank you.